You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 465 of the podcast. And in this one, I chat with Molly Schiffer. Molly is a therapist and Associate Director at the Centre for OCD and Anxiety at Sheppard Pratt. And in this episode, we discuss her therapy story, cognitive processing therapy, or CPT for short, trauma and OCD, CPT for trauma, how trauma can fuel the OCD, CPT helping exposure and response prevention therapy. Molly shares a clinical case example of CPT in action, and much more. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. Thank you to all of our patrons for supporting our work. To sign up to our Patreon and to check out the other benefits you'll receive as a patron, please see the link in the show notes. So thank you to you guys for listening as always, it means a lot. And thank you to Molly for her time and expertise, I appreciate it. And this episode we do explore trauma and OCD in a bit more detail and how trauma can sometimes affect OCD therapy, such as exposure and response prevention therapy. And Molly lays out the case of why CPT can help work on the trauma, which can in fact sometimes make the ERP easier. Without further ado, here is Molly. Welcome to the podcast, Molly.
Thank you for having me.
Yeah, it's good to have you on. So we obviously have met, right, in Denver. It was literally the pandemic, right? It was not like a week before lockdown in both of our countries. We were at a Game Changers event.
Yes, I remember it vividly. There was the hand sanitizer bottles all around, which is abnormal for our community.
Yeah.
It was like right before they shut everything down.
Yeah. I remember us eating in that diner at the lunchtime of the event.
Oh yeah.
Nice. But yeah, good event, and obviously nice to meet you there. So, it'd be good to hear your therapy story. So what got you into becoming a therapist, then specifically working with OCD?
Yeah, so I have had OCD since as young as I can remember. I can remember like my first moment when I had this thought, and it was really my very first, I think, obsessional thought. But back then I don't think that it was talked about very much. And so really I didn't really talk about it a whole lot until, it became a real problem. So I actually am like third generation in my family of people who have had OCD. And I didn't get it diagnosed really until I was in my, I would say, early 30s. And I can remember the time at which I decided like something's wrong. This is too hard. And I decided to get help. And the thing about it was really, since I was very young, and when I was in school, I can remember going to a counselor and trying to explain my experience, trying to get some help because I knew something wasn't quite right, couldn't pay attention. And he really was a lovely man, but had no idea how to respond. And so when I did get the diagnosis and I started evidence-based treatment, I remember thinking, oh my gosh, like there's a solution, like there's something I could do. And it really sort of planted this seed that I could do this. And up to that time, I really hadn't thought about it. But when I started the treatment and it made a difference, I wanted to not have other people have that same experience that I had, where they try to present their story and nobody has any idea of what's going on with them. And so, I went back to school and, started my career in my very early 40s. And I always say, uh, this is absolutely my dream job by far.
Mm.
I always joke with John that I would have worked for him for free. That's how much I wanted to do this job.
Yeah. Only tell
Yeah.
him that once he started paying you. So then,
Yeah, exactly.
yeah, yeah,
Exactly. Yeah.
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 Wow. And how did you? So John is John Hirschfield. For anyone not
Mhm.
clocked that yet, or maybe doesn't know John Hirschfield. John. I interviewed him many times, but recently for his work at Sheppard Pratt, and it was on an inpatient episode. And of course, you work now with John at Sheppard Pratt. But
Mhm.
before that, you were working with him in his private practice. So how did you meet John? And how did that develop?
So I, right before I got my license, I attended my very first international OCD conference, and I remember I had no idea who he was. I was just sort of completely new to the conference, and I remember I was sitting, and he was speaking, and he made a joke, as he frequently does, and the way he talked about OCD was a way I'd never heard anyone talk about it. And I I picked up one of his books, and like it was so powerful to have it written in a way that really matched my experience. And then I learned he was in Baltimore. And I was blessed enough to have somebody, send him a quick email saying, "Hey, I know this person that, would love to, work for you part time or anytime at all." And so I just met him. And I think we would be in agreement that we immediately, you know,
Clicked.
we clicked. Yeah,
Yeah.
absolutely. Um, so yeah, that was really how it started, and so I've been working with him since 2017,
Wow. Cool.
both
Amazing.
private practice and now here at Shepherd. Yeah.
Yeah. Yeah, that's brilliant. And just to check, and I did ask John this on the recent episode, because he'd
Mhm.
been private practice outpatient his whole life, weekly or maybe twice weekly therapy, and then suddenly he's in this more intensive inpatient setting. So what's that been like for you, that change?
I actually love it so much. Um, I think it's interesting when you're in school and you're thinking about what you want to do. You don't really know until you're doing it. So I had started off thinking I just wanted to work with children, and then I discovered when I was working in an outpatient community center that I didn't enjoy that very much. I didn't feel like that came naturally to me. So then I just, wanted to do outpatient once a week. Hadn't really thought about working on a more intensive level. And so when we moved here, it kind of started slow. You'd see one or two retreat patients, and I had a full outpatient caseload. And then the longer I started doing it and the more closely I started working with people, the more, to be honest, I fell in love with it and am sort of moving into this, just more retreat patients and trying to kind of back away from outpatient to some extent. There's something about getting to work with someone several times a week, be in the muck with them at their hardest moment, and get to be a part of them discovering a new way of living and relating to their mind, which
Yeah.
is just so amazing. It's an honor.
Yeah, wow. And do you see because obviously in outpatient, we see clients typically once a week on average. And sometimes to see them understanding the concepts and making changes can take a while. Do you see it much more rapid in the inpatient setting when it works, obviously?
Yeah, I think so, but I think it has a lot more to do with the people that are in residential are very, very severe,
Mm.
especially where we work. So there's a lot of comorbidity. And so I do think you might see quicker results than you would. But the quicker results doesn't always correlate with more functioning yet. Like they still have a long way to go, but you get to see the changes much more quickly. Plus, I'm upstairs from the retreat, my office. And so you get to see them on the unit. You get to witness them trying new things, which you don't really get to see. So it's possible that people in outpatient are also doing, things that I would go, oh my God, that's progress. But here I actually get to see it. I get to witness them interacting and doing hard things, doing exposures. So I get to see it firsthand.
That's a really good point. Yeah, as weekly therapists, so to speak, we don't get to see our clients living their lives and being brave and doing all of those things. We hear about it, but we don't get to see it. Yeah.
Yeah, and you also get to see them when they come in, like day one. And day one, and you get to walk them through that first weekend, which is always the hardest. But you see such a transformation when you see a person, like, even though I'm only meeting with them, say, 3 times a week, but I see them walking around, I hear about them in group, and just see the transformation by the end, most of the time, there's quite a transformation.
Yeah. Wow. Yeah. Thank you. So we're going to talk about cognitive processing therapy. Did I say that right?
I think so. Cognitive. I think your accent made it sound fancier, but
yeah, cognitive. So I have no experience with CPT. I'll just call it CPT from now on. I have no experience with it. It's I maybe use different approaches with trauma. So I even had to, YouTube what is CPT before this to try and understand. That's how little information I have on it. So just giving you the preamble so you can treat me like an idiot and I won't be offended. So yeah, I'm really interested though to learn about it, as I am with all therapies. And maybe there's a question there of why haven't I've definitely heard of it, but I haven't heard of it a lot. And I think I'm pretty well versed on a lot of therapies. So maybe the first question is, why may I not, I can't, I'm trying to say, have not heard of it that much. It might be a cultural thing. It might be that I'm in England and it's not that big here, or I don't know. Yeah.
Yeah. Well, I think there's a couple possible reasons. I don't know about, who you see on a regular basis, but I know that for me, I was immersed in the OCD world where the idea of going into content and spending much time, thinking about content or even analyzing content was like almost a taboo. Like, we don't do that, right? Content's irrelevant. And so I think just probably not being exposed might have to do with, being an OCD specialist, possibly. But the other thing is even though it's an evidence-based treatment, I don't think it is something that people hear a lot about until they maybe experience, like I did, in outpatient. Some of my first patients, they presented with OCD. A couple of them had very, very sort of long-standing childhood trauma. And they made so much progress with the OCD. But I started to notice this pattern where there were certain symptoms that just didn't really remit. And it seemed to really it seemed to be a connection between the two. And so I started to sort of wonder about this idea of content is irrelevant except for when it's relevant. And we kind of don't. I was trained to sort of think, well, trauma has nothing to do with OCD. OCD is and it was kind of protective of that idea. But my own experience was I was also seeing this sort of effect where the more they got better from the OCD, the more these other symptoms seemed to show up, like depression, suddenly starting to really notice having difficulty with ADLs. And it was sort of this ping pong effect that made me curious. And so my first couple patients, I decided to refer them for trauma treatment. And it was with the understanding that, they'd see me for the OCD maybe once a month or whenever necessary, and they would see this other specialist. And knowing that CPT was an evidence-based treatment, I referred them. And as they got better, like I really noticed a significant change, and they were able to address what looked like OCD symptoms, but really were more indicative of like PTSD, CPTSD. Yeah. And I kept seeing that, and then I started to see it a lot here at the retreat. Started seeing this sort of hybrid of OCD and PTSD, where if it's not, doesn't meet the criteria for PTSD, then trauma or CPTSD. Yeah. And so that's what led me to research it. That's what led me to go, I need to get some training in trauma, because here I am, and my skill set at some point, wasn't enough to get them over the line. Yeah. And so I got the training a couple of years ago, and I think it's kind of important to say that this matched my own lived experience also. So I had gotten significantly better from the OCD treatment, but there were certain long-standing difficulties I had with like interpersonal things. And it really was related to some traumatic experiences in my own upbringing. And so I noticed like, oh, wow, this is my experience too. I was always hard on myself of like, why can't I get better at this area? Why am I not making progress here? And I was like very judgmental instead of understanding like, oh, this relates to something else. And so it really was kind of freeing to know that. And we see that a lot here too, where we have patients that come in and they're sort of labeled treatment resistant. And what we find is a good percentage of people that are treatment resistant or labeled treatment resistant have a long history of trauma. So I started that training, and I did the consultation, and we started doing sort of this model of, we'd have the OCD when it was appropriate, we would have the OCD team seeing them, and then I would see them as well for CPT when it was appropriate. And then now I've started sort of branching out, and sometimes I see people for CPT that don't necessarily have OCD, they have anxiety. But we've really found it to be quite effective and necessary to treat them side by side a lot of the time. When there's a relationship between the two, which there often seems to be this dynamic relationship between the two, they really need to be treated side by side. Otherwise, you just see this ping-ponging effect of getting better in one area and then it sort of falling back into depression and increased suicidality. So that's really how it started. But like I said, I didn't know of CPT until I saw these clients getting better in these areas that they had been stuck for quite a while. And, if you want to hear more, like I have an example of that with someone where it really did make a difference to be able to look at what was keeping her stuck.
Yeah, I definitely want to hear the examples, and I assume the listeners love the examples too, but I know I definitely do. So, but before that, it'd be good to just define what is CPT. Like I know it's obviously a therapy for trauma. What we all know what ERP is roughly, So what does a CPT session look like? What are you targeting? What's the focus of the work? Yeah, what could people expect?
Yeah, well, so what makes cognitive processing therapy different, I think, from ERP is it really is this cognitive model that is looking at people who have had these traumatic experiences and how they, like, what got in the way of them fully recovering from the trauma. Because what we do know is most people do recover from trauma. And so cognitive processing therapy is looking at the the way you're thinking about the trauma. So how you made sense of what happened to you. And so CPT conceptualizes PTSD and CPTSD as being an interrupted recovery. And so, like, what got in the way? And one of the big things that gets in the way is this avoidance, a huge amount of avoidance of internal, external reminders. And also this sort of overactive amygdala, which keeps the brain being able to think critically and objectively about the traumatic event. So what we're trying to do with patients is in like from session 1 is I educate them about here at the retreat, right? So we get more CPTSD than clients with our OCD. But in the United States, right, we don't actually diagnose that. Mm-hmm. So, but it's recognized. So I will just give a general sort of psychoeducation, depending on where they're at with that diagnosis, about trauma and how it affects the brain, and how the way they've been thinking about something is what's keeping them stuck in these emotions of shame and guilt. And so it starts with just a lot of psychoeducation about what is the cognitive model. And, you know, there's more detail about how the cognitive model conceptualizes the PTSD. And so there's something that we're looking for specifically, which is the stuck points. Mm-hmm. And when we say stuck points, what we're looking for is these sort of rigid, exaggerated, all or nothing type beliefs about why the event happened, what it means about you, how it impacts your relationship with others, you know, self-esteem, intimacy, power, and control. And when I'm doing CPT here with patients, you know, it's 3 times a week. So it's very homework oriented. You know, we have them write an impact statement, and how this is a little bit different than other trauma therapies is that this impact statement is not a trauma account. It is, what have you been thinking about why this trauma happened? And there's 2 types of stuck points we're typically looking for. We're looking for stuck points that are sort of based on this just world belief, where a person, you know, is looking back at trying to understand why something happened, and their understanding of how the world works is based on what they believed before the trauma. So if before the trauma, they sort of believed that good things happen to good people and bad things happen to bad people, which is something that most of us are taught. We're taught that in school. We're taught that in church. We're taught that by our families. And so it gives us this sense of, you know, having some kind of control over the world, right? If I understand that the world is fair and that if I do things right, then good things will happen. When trauma happens and that doesn't match up, you're left with, well, how do I incorporate this traumatic event into my current understanding? So in a perfect world, those that recover are able to take that event. They're able to work towards processing, not avoiding, experiencing, you know, these thoughts and working through them, and sort of incorporating that traumatic event into their understanding of how the world works. And so they may have a more flexible understanding that, you know, good things happen sometimes to bad people, and sometimes bad things happen to good people. So what happens in a situation where someone is stuck is they often start saying, well, what does it mean that this happened to me? What if good things happen to good people, then, what does this mean about this traumatic event? I must have done something wrong. And this is like perfect fodder for OCD, moral scrupulosity. And the other type of stuck point we're looking for is ways in which someone's belief about the world, they overgeneralized. So, for example, if somebody had already maybe experienced traumatic events and they already were not trusting the world, already been exposed to trauma, they may go to the whole world isn't safe. I can't trust anyone. And so these overgeneralized and these sort of rigid beliefs about just world are what we're looking for. We're looking to challenge them. And so it's a series of worksheets that we sort of introduce the concepts of like this connection between these triggers, these thoughts about the trigger, and then these emotions that are what we kind of call manufactured emotions. These are emotions that come as the result of what we've been saying. So they tend to be shame, they tend to be disgust, and those emotions are not something that we can process in the same way. So CPT seeks to help people look at this and challenge what they've been saying to themselves. It's sort of like we're trying to bring that the brain back online, the prefrontal cortex back online, so that they can take a look at the information and sort of say to themselves, like, is this really accurate? Is what I'm saying about this event really true? And through that process, we help them to get a more nuanced, more flexible thought about the trauma. And that allows them to move forward, which with OCD, in a lot of ways, that can help them move forward to do the ERP.
Absolutely. Really, really good breakdown. I'll definitely have to listen to that back to really process it more.
Yeah, I mean, there's so much.
No, but it was, you did a great job. So yeah, it is targeting trauma from a cognitive point of view. So the cognitions that are maintaining the story of the trauma that's then keeping it going. Is that okay?
Yeah. And it is kind of amazing to see. When I first started doing it, I was a little skeptical about the worksheets because I thought, how powerful can these worksheets be? But I've really seen sort of the lights go back on when people go, wait a second, that's not quite right. And I've seen rapid change in people's, in how they do moving forward once they change that thought. And even though that changed thought isn't, just something super rosy, and it's just more objective, and that can allow them to work through those exposures that are necessary to get recovery in OCD is also in that area.
Yeah. That's really fascinating. And I guess if you're targeting the cognitive side of things, well, I'll ask it now, and then I'll ask you for a real world case example. So the cognitive side of the trauma, and obviously there's the cognitive side of OCD, which is the intrusive thoughts and the worries and all of that. And I'm just assuming that obviously if the trauma is fueling the OCD, do the cognitions from the trauma in some way fuel the OCD? I know there can be sometimes a direct link between the trauma and the OCD content, and some, what do they call it? Static link, and then dynamic link, where it isn't always obvious.
Yeah. So when it is a situation in which the OCD and the trauma symptoms are separate, it's much more sort of clear cut about how you can proceed with treatment. But when there has been traumatic events and the way a person sort of made sense of it was that maybe something's wrong with me, maybe I'm not a good person, maybe I did something wrong, that can translate to increased symptoms with OCD. Especially we see that a lot with moral scrupulosity. Often my patients that I see that have both have a lot of moral scrupulosity, and it's directly linked to kind of what they believe about the traumatic event. So when it's a dynamic relationship, it's not always that the OCD matches the trauma, but sometimes the content of the trauma can fuel the OCD obsessions as well. Especially there's a correlation, right? For those that experience sexual violence, we commonly see that translate in OCD to contamination. And a lot of times that's a feeling of disgust they feel inside. And then it's externalized in this sort of contamination, which we see quite frequently.
Yeah, that makes perfect sense. So a couple of questions ago, you mentioned that you had a case that you thought would be a good illustration. So please feel free to share that.
Yeah, so one of my cases that I was working on early, this person presented with, sort of a smattering of common OCD symptoms. So this is a person that had it all their life. And being a new OCD therapist, I was like all in, super excited to, do exposures. So, there was a lot of moral scrupulosity, worry about sort of, am I flirting when I shouldn't be flirting because I have a boyfriend? Am I doing something wrong? Am I dressing inappropriately? There was a lot of rituals that we were seeing in the shower, rituals around using the restroom. And we did a lot of exposure. We went all around Hunt Valley, going to stores, practicing talking to salespeople, not avoiding wearing certain clothing, and working on reducing the shower rituals. And she got significantly better. But what was clear was that all of a sudden depression would really set in. And she wouldn't be able to really function very well. And I was already aware of a childhood history of trauma, but it wasn't something we really discussed a lot until it became sort of obvious that her OCD seemed to increase whenever she was interacting with her family. And there was a lot of religious trauma from her past. And I started to notice that the shower ritual and the going to the bathroom and this whole ritual around wiping was related to these beliefs about women's bodies and about experience she had when she was very young. And so whenever we would work on decreasing those rituals, it wasn't enough. It was like she'd maybe make a little bit of progress, but then we would find that, she would just fall right back into the depression. And so this is a really good example of a person who, presented with all these trauma, and we were presented with all this OCD, and we were able to work through a lot of the really obvious overt OCD symptoms. But there was this fundamental piece that she had from this sort of religious training that was leading to these compulsions that were based on the idea that a woman's body is dirty, is disgusting, and that would lead to intensive episodes of sort of wiping excessively to the point of bleeding, scrubbing with nails. And so this is one of the patients that I did refer to someone to do CPT. And once that belief was challenged, and once that was looked at and worked through, and if the emotions were processed, she was able to do the exposures, really, and was able to reduce those rituals because we challenged that belief she had fundamentally. It was keeping her from learning what she needed to learn in ERP because she had this fundamental belief about being dirty and about being bad. And once we were able to help her come up with a more nuanced way of thinking, she was able to do the exposures and able to recover. Now you're always kind of walking this line of like which is the OCD and which is the trauma, because you don't want to be feeding into the OCD, and so you're kind of doing this balancing act. But that was like a really good, powerful experience for me to see when content can bleed into OCD and is important to have a better understanding of, at least.
Yeah. Yeah, fascinating. So the ERP obviously worked somewhat, but then it was hitting a brick wall, which was the belief about the trauma or the experiences.
Yeah.
It wasn't until the belief was changed, because I guess she wasn't going to expose herself or do ERP to something that she really believed.
Right. Right. Which is different, right? Because it's more ego-syntonic as opposed to most of the time with OCD, the obsessions are ego-dystonic, right? And I think sometimes I don't want to say the ERP is easier because we know it's not. But I think you're able to approach those exposures. I think that it's not easy, but people with OCD, right, probably most of it, at least for myself, is like I mostly know something's not true. I just a little bit, right? Have this doubt that feels like it's a 75-25 or 50-50. Whereas when there's a belief like, no, this is true, like there's something wrong with me, I'm bad, and then to approach something and where they're like not doing the thing that they think is necessary because of this belief, that's a hard sell. You really, it's difficult because it's ego-syntonic. And so helping them to change that allows them to approach it more like somebody that had an understanding that, okay, I have this thought, it's repetitive, it keeps showing up, and that's predictable for me, but I can disregard and bring myself back and not engage in compulsions. So once that was sort of moved and changed, she was able to approach it to get the learning.
Yeah, that's really fascinating. It brings to mind some of my own clients thinking about and we'll have to reflect on. Yeah. It just makes me think generally what beliefs get in the way, whether it's trauma or just general beliefs get in the way of people's recovery.
One of the things that I think is good to talk about is therapist flexibility. So when I was first learning this model, right, it was very strict for like, this is for PTSD. We do it this very specific way. It's a manualized approach. And kind of in line with what you just said, I started to notice like, well, it's not always, sometimes people without, a criterion A trauma will have a core belief that gets in their way. And so it was my own exposure to change up the manualized approach a little to what matched with my actual patient, and to be able to say, okay, this person could really benefit from doing part of this protocol. And starting to help patients that, maybe have core beliefs and they don't have PTSD, but they could benefit from changing that belief anyway. And so there's times where I use the full 12 to 18 session protocol. And then there's times where I just take some of it. And so being flexible and especially when it's OCD and trauma, I think you have that room to be able to be flexible with how you approach the treatment.
Yeah, absolutely. Yeah. The manualized interventions are good, but no human is a robot, right? They're varying and different, and the treatment needs to vary and differ.
Yeah. Yeah.
Yeah. Okay. So, I was going to go on a whole rant then about research, but I won't.
Oh,
Okay.
you were going to talk about research? Go ahead.
Well, no, just
Yeah.
manualized treatments.
Oh,
Okay.
yeah. Mhm.
So, just looking at the questions, I guess I'll ask, how can CPT complement ERP? How can they work together? You have talked and mentioned it, but just to ask it directly.
Yeah. I mean, the way I think it complements it is that, like I was saying earlier, that people that are struggling with OCD and they've already tried ERP or they've been doing active ERP, but they're not making progress in these certain areas, and then we are able to identify that they do have these core beliefs that are getting in the way of them being able to do full ERP and getting better. It can complement it because really it helps them to change the beliefs so they're willing to do it. Helps them to be motivated to do the exposure, and the exposures are still necessary for them to do because avoidance is such a big thing in trauma and PTSD. So I think they complement each other because they help the person not only feel confident that they can do the exposure, but to be more motivated as to why they would want to do an exposure. I'm always asking the patients I work with in general, like, why would it benefit you to do this exposure? Just like what do you have to learn that would help you in your life? And that usually helps them to be like, okay, I need to get better at tolerating this distress. So I want to do this exposure for that reason. And when somebody has trauma, they can trying to help them understand why it would benefit them to do this when they have this belief that hasn't been changed is difficult. You can't really, there seems to be a block. So when we do this side by side, it's sort of like I'm helping them sort of challenge, look at what they're thinking, which translate to changing their behavior, if that makes sense.
It does make sense. And I guess what's in my head is like, if we stick with the idea that OCD is just this biological condition and it is just the brain malfunctioning, and then I don't massively wholeheartedly agree with that opinion, but let's just say we stick with it. And yeah, doing exposures is hard and it's scary, but you're kind of going against a brain malfunctioning. It's a complete imaginary threat. Now, if the OCD is somewhat symbolic for the trauma, which I guess is what we're saying here, then it's not way harder. It may feel harder to do the ERP because you're actually going against the traumatic experience. It may not be cognitive and self-aware there, but it's on some unconscious level, you're actually facing what was once a real threat, or at least the memory of it.
Yes. Yes. Exactly. Exactly.
Which, yeah, obviously then you need to do the trauma work to do the ERP.
And sometimes I think that when I'm working with someone that I've been doing ERP and we discover that there's this sort of trauma piece that we need to address, a lot of the time they weren't ready to address it yet. So it's not that, I think it's sort of like when you're doing both side by side, it's like they're kind of like they're able to sort of wrap it up, like in the sense of like those that have already made a lot of progress in the OCD, but they have these symptoms that haven't remitted, so they didn't get this sense of like, oh, I've recovered, or I am in recovery. It helps them to be like, okay, so now I've done this other thing too, where now I've like brought in my understanding of how trauma has played a role in me not being able to really fully get the benefit of the ERP. And it's sort of this kind of like second level of recovery of like, okay, I had to do what I could with the OCD in order to be ready to do the trauma, but I can't recover from these OCD symptoms entirely until I also adjust the trauma.
Yeah. Yeah. Fascinating. Fascinating. So, I'm just looking at my questions.
Yeah.
Maybe it's just another direct question of like, how do we differ between trauma symptoms and OCD symptoms? Like, what are the key things you're looking out for, or that the listeners could be looking out for?
Yeah, I mean, sometimes that's really difficult to tease apart, right? They can be very similar because in trauma, right, like in PTSD, you're going to have those intrusive symptoms. You're also going to have the avoidance. So I would say that some of the key differences, or the way I try to make it make sense, is what is driving the behavior. So is this a case where there's an intense amount of urgency, where they're trying to get certainty, they need to know 100%, right? That is so indicative of OCD, versus some of the patients I work with, right, that they're having those intrusive thoughts about being a bad person, or and their concerns are more related to safety. They're less about, I need certainty about just this general like ego dystonic thing, versus certainty about my safety. And so there's a different quality to it that I look for. I often say that like OCD is identified not by necessarily the content, but the way it feels, the way it acts. So, it's like intrusive, it's repetitive, but it's also this like sense of like, I have to do this thing no matter what, even if it makes sense or doesn't make sense. Versus when somebody is acting out of this safety, acting out of safety, trying to get safe.
Yeah, that makes complete sense. Is it fair to say with OCD there's maybe much more of an irrationality to it?
Yes, I would say so. I mean, I think that's the ego dystonic piece, right? There is, but I also think it can be helpful for people to. I do think that even though there's an irrationality to it, even when a person maybe doesn't have a lot of trauma in their life, some of their OCD still could be, right? It could be helpful to understand that, like, oh, maybe I'm more stuck on contamination because, my mom was very rigid about cleaning, or very nervous about health. It can be helpful to have an understanding of sort of where that came from. So I would say that there is an irrationality to it a lot of the time, but sometimes there's also just like, well, they partially got stuck on it because of their previous experiences. And that's not necessarily related to trauma, but just to kind of what they've been exposed to growing up.
Yeah, that makes sense. Well, it's been really interesting on CPT. Is there anything else you want to say about it?
I guess the only thing I would say about it is that I think that CPT has really sort of opened my own mind about recovery and what we're looking for in recovery. And it kind of reminds me of the importance of me being teachable and flexible, because initially, right, I was just like, no, these are not connected. I was very invested in that they're not connected. And so learning about CPT, even though initially I was kind of like, really, manualized 12, 18 sessions, like I'm not so sure about this, and really worksheets, and also just like, no, we should never, never, never talk about content. And learning that, right, often we see with OCD, one of the big qualities is a black and white thinking, and that's my own black and white thinking is this, you never talk about content, right? So I guess that's what I would say. It's taught me a lot, and helped me a lot, to look at what am I saying to myself about things. Yeah. And maybe I don't need a full protocol, but it's helped me to be able to think about what am I saying to myself about certain things and how is that impacting how I behave?
Yeah, it's a really good point. I think, we do talk about black and white thinking in CBT and OCD and I've definitely been guilty of black and white thinking. And I know there's a lot of therapists that have come on my show and have talked in very black and white ways about OCD and ERP. And it's kind of ironic that we're acting in that way, but teaching our clients not to.
Yeah.
Maybe we need to take a long, hard look at that. But we all do it. It's just human, I guess. Yeah. So, 20-year-old you, pick up the phone, call her. What would you tell her?
There's always hope. There's always hope. There's hope if you're breathing for change. And I guess that's what I would say, because I think that's the missing ingredient for a lot of people when you've lived with OCD for a long time untreated, or when you've lived with really any mental health condition for a long time. It can be very demoralizing. So knowing that there's hope can be life-changing. It keep you going long enough to get the treatment.
Yeah, I like that. So you got a billboard. What do you want written on that billboard?
Oh, that's funny because John told me about this, but I had no idea what you actually mean. So what do you mean, something on the billboard?
It could be literally anything you want in the world. It doesn't have to be OCD related. It could be, but it doesn't have to be. Just a message, maybe for the world, your community.
Probably, there's always hope.
Yeah. Nice.
There's always hope.
Yeah,
I guess that would be it. Simple.
Yeah, well, it would obviously appeal to many people driving past or walking past that billboard. Yeah. Okay. So, lastly, anything else you wish you could have said or shared today about anything?
The only thing I'd say is I feel very honored to be on your podcast. I've been listening for a while. I recommend it for a lot of people. I'm grateful to do the work I do. I consider it a real honor to get to hear people's stories and be a part of it. So I just appreciate you having me on and the work you do in the community. And thanks for having me.
No worries. Yeah, thanks, Molly. I appreciate it. Of course, thank you for your work and also sharing CPT with me and the listeners. I've definitely learned a lot, so thank you. Thank you for listening to this week's podcast, and thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us, please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/the OCD Stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.